I'm sure the host will allow time for questions. So, as we already saw, the percentages are big. It's very common and it affects any age, though it is more common in those over 40 years of age. Of course, we know that there are associated health difficulties that come with aging. So we have what we call a sexual response cycle, and it is the basic of what I want every one of us to know and understand. So the sexual response cycle includes a stage called of excitement. So excitement, then we have a stage of plateauing, then finally orgasm. And after orgasm, then resolution. Resolution is like an end of what has been going on. So, of course, desire, looking at a female or a male, a man or a woman, and you get desire or arousal are both part of what we have called the excitement phase. So, excitement phase is you get someone, you see someone, your partner, your wife, your girlfriend, and your boyfriend, and you feel yes, there is a desire for this person, and also there is arousal. Now, when it comes to women, we have to know that they don't always go through these phases in order, in the order that I've talked about. This is the order I've talked about. We have excitement. So this is a sexual response cycle. So we have excitement. Then it is during this excitement that uh, we find time for romance, behaving in such a way as to show one that you're interested in someone, but also the real act of trying to have romance. And it takes, I mean, we sit down, we have time and arousal. So arousal keeps on increasing as time goes on with excitement, especially if both are involved in the sexual act, are interested in it. Now, the sexual act itself, that may include the kissing, the caressing, the penetration, start during the course of the excitement phase, and then there is plateauing. Now, plateauing is the time that a couple, is involved in what we call sexual intercourse, and then finally we have, as we can see here, we have an orgasm, and after orgasm, there is resolution. Now, a problem can happen at any point during this cycle, as we are seeing. So anything that goes wrong during any phase of this sexual response cycle is what will prevent one from experiencing satisfaction from sexual activity. So, and this is what we are going to describe part by part. And maybe as we do, I know you know someone out there that may be having these difficulties. So when one comes to the hospital, these are some of the questions that when we are examining or when we are trying to identify what the problem is, we go in this order. Now, there are people who have desire disorders. For them, they completely have lack of sexual desire or interest. They are not interested. Tebagala kumanya. That is the street talk we say, how we say it currently. So this can come. There are also those who have still a desire disorder of sexual aversion, like they are not interested. Also, they don't care if it comes. Yes, if it does, they don't give a damn. But also we have those with excessive sexual drive. So having excessive sexual drive is also a disorder. It is a disorder. The people who will see every skirt and they want to run at it, irrespective of if it is the other scarecrows in those rice fields to scare away birds. If they sit in a skirt, they think, oh, those ones who see these We get some people, these people who see, are they called mannequins? Those at clothes shops. Then someone is turned on by such a mannequin that is having excessive, so it's also a disorder. So of course, this disturbance causes marked stress, and especially for those who have lack of desire, but also those who have a lot of desire, excessive sexual desire, those ones also can get a number of interpersonal difficulties, especially when dealing with colleagues, workmates of the opposite sex. Now we have a second group already, the arousal disorders, and we said these two are part of the excitement phase. So there are those ones who are unable to get or to become sexually aroused or excited during sexual intercourse. And this affects very many people, very many women, and even men at different stages. A woman is married, she has got children, but has never enjoyed sexual intercourse. She just does it because it is more of a responsibility, because she knows she got married and she's going to have sex. There are those who even get failure of genital response. During sexual activity, the responses are expected from the vagina, we expected lubrication, but for some it may fail. Of course, in males, there may be failure for the penis to erect. So those two have arousal disorders. So, and as I have advised when we are going through this, we try to make sure that the people we know or the people we have shared with, or even ourselves, you try to see where you can always advise someone to be helped. So there are people who have orgasm disorders. And by orgasm disorders, um, is delay, for some there is delay or absence of orgasm. This is quite common in women, and there is literature that suggests that not every time a woman has intercourse will they get orgasm. But yes, orgasm, women should get an orgasm. There is also a lack of sexual enjoyment, I mean, and for some men, there is premature ejaculation. Now, I know questions will come along the way. People may want to know what is premature ejaculation, but the normal duration of sexual intercourse is between 5 minutes to 40 minutes. Now, that means if someone comes or ejaculates before these 5 minutes, then they have premature ejaculation. But also, if someone delays to get an orgasm or to ejaculate after 40 minutes, then those ones are also having an orgasm disorder. And there are some people, both men and women, who will get pain during intercourse, or what we call dyspareunia. It's quite common. The most common causes are those who have had infections, pelvic inflammatory disease, the so-called PID, the gonorrhea, the chlamydia infections. All those can cause the vulvovaginal candidiasis, or candida as we call it on the street. Those two can have pain during intercourse. But some of these issues really fit into each other, because for some they'll get pain because of what we have talked about in the previous slides. So just more about desire disorders. Desire is what one may call libido, and usually someone has spontaneous sexual thoughts and fantasies, and attentiveness to anything sexual in their environment that may stimulate them. It can be visual, as in something that one can see, or something that one can hear. You hear certain sounds and they turn you on, or tactile. You get a certain touch on specific touches on specific parts of your body and they turn you on. If anything goes wrong, then at any point here, then one has a sexual disorder. So we want to know what are the symptoms of sexual dysfunction in men. I mean, just to make it really straight, but I've talked about it. Inability to achieve or maintain an erection or a hard penis suitable for intercourse. Without a hard penis, you can't have sexual intercourse. We already talked about absent or delayed ejaculation despite enough sexual stimulation. And some have inability to control the timing. I mean, the early or premature ejaculation that you have talked about. In women, the biggest problem reported is an ability to achieve an orgasm, then inadequate vaginal lubrication before and during intercourse, then inability for some to relax the vaginal muscles enough to allow intercourse. Of course, this you have heard about people who are in the sexual act and then they get stuck in their what we call vaginismus, but also those who are having their first or sexual intercourses, they may get that. But some problems are common in both men and women, lack of interest in or even desire for sex, and some are unable to become aroused, and both can have pain, as we talked about. Now, what are the causes? Of course, for some reason, these things, alcoholism is always, for every problem in medical or in diseases, alcoholism is always um, almost always a problem. It's always a problem. And the drug abuse, by drug abuse, we talk about smoking, abuse of a number of drugs, opioids, marijuana, heroin, cocaine, all these. But for some unfortunate people, let's say those with diabetes, usually their nerves, those small wires in the body get sick, and therefore it makes it hard for them to to um, to 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 erect or even sustain an erection. The commonest, but the doctors who are watching us very well know. I think I'm going to put on the video just, I think, for a short time. Yes. So the doctors who are here, I'm sure they know some drugs like tricycline and depressant, drugs like amitriptyline. Amitriptyline can actually be problematic. Um, then metoclopramide. Metoclopramide or Plasil is a drug that people use, some who usually get issues with motion sickness on the bus. They use it to prevent vomiting, but also it is used in hospitals to treat a number of issues, especially if you think a patient is likely to vomit. So we give them metoclopramide. So that drug can actually cause sexual dysfunction. Then rezapine, methyl-dopa is also quite common. Cimetidine is also quite common. The drugs we use in normal diseases, so usually sometimes the problem. Even nifedipine, some drug called nifedipine, we use it a lot for people who have hypertension or pressure. Now, for some people, they may get difficulties uh, of sexual function due to increased levels of the hormone called prolactin, especially in men, even women. So when they come as part of the assessment that we shall look at, they may get issues. Now, those are some of the issues. But now the biggest percentage, almost up to 90% of the causes of sexual dysfunction are actually psychological causes, up to 90%. Of course, there is an advantage to this. I mean, if it is psychological, it should be easier to treat, but sometimes it may be hard to handle or to treat. Some people have work-related stress. Their assignments are many. They are not meeting their targets. Some people are anxious. That will surely make the sex act not as desirable. But also we have people who just by the mere fact that they are presented with a sexual event or opportunity, they will have anxiety or what you call performance anxiety for their partners. Someone knows this is my husband, this is my wife, this is my girlfriend, but maybe because of some previous experience or some other underlying factors, they are this time concerned about how they are going to perform. Or even while they are at it, what one partner makes a comment that actually switches off the other one. Then, especially if it is about the sexual act, that may disturb the performance. Then, of course, people have marital relationship problems. Those people have depression, feelings of guilt, and history of past sexual trauma. This is quite bad for both men and women. Those who have suffered rape or have had any challenges related to sexual abuse may also have such challenges. These are some of them. I'm going to let my colleague, Dr. Masembe, to proceed. But I will also ask that please note questions at any point, and specifically when the time for asking comes, I'm going to start looking through some of the questions. Then we should be able to answer them. Thank you.
Thank you so much, Dr. Hilary, for the wonderful presentation. I see some questions in the chat, but like I've mentioned, we shall go through them later. Now, let Dr. Masembe take us through the management bit of the discussion, and then we shall respond to all the questions at a go. Thank you so much. Dr. Masembe, you're welcome. Dr. Masembe, you are still muted. Unmute your microphone.
I suggest that Dr. Hilary put off his screen show. I suggest that Dr. Hilary puts off the screen show so that Masembe is able to actually show us his slide.
Okay.
Stop. So then you can see. You can see. So I want to see that my slides are moving. Okay. Okay. I just want to know that everyone is seeing my screen.
We can see your screen, yes.
Okay, and you see my slides moving.
Sure, sure.
Perfect. So good evening, everyone, once again. I'm Dr. Masembe Cesario, earlier introduced. I'm a gynecologist, obstetrician, and a fertility specialist working with NeoCare Clinic and Fertility Center, Mbarara, and also teaching in a number of universities, including Mast, Cavalry University, and others. So good to have you this evening to share some of these important aspects of our practice. I'm going to basically talk about management of sexual dysfunction disorders, and you start with these general gender differences in sexuality. We know men and women respond differently to sex. One is that men are usually genital focused, whereas women are focused on intimacy and relationship. Then the performance is usually the goal in men, whereas women look at sex in a broader context. Men usually go through mandatory orgasm, whereas in females, it may or may not happen. Visual stimuli, as my colleague later earlier talked about, are usually of prime importance in men, whereas in women, visual stimuli may instead distract them. Then tactile stimulus in men is usually distracting, whereas in women, tactile stimulus is very important. All right. When we are assessing sexual desire, we take a few questions and we ask women and men if they are able to experience pleasurable thoughts about sex, okay? Then we ask them if they are able to initiate love making. Are they able to get and stay aroused? For men, in this case, are they able to achieve an erection and maintain it? And for women, are they able to get genital lubrication? Those are signs of arousal. Then we ask them if their minds usually get those sexual fantasies or sexual thoughts. Then we ask them, do they respond to partners' overtures or advances? Okay. Then are they able to stimulate themselves? Do they ever miss sex? All these are questions that usually help us to know if someone has a sex desire problem or not. So general considerations, again, we want to ask them if they are taking any medications that could affect their sexuality. And in that case, we have to withdraw those drugs, including antidepressants and hypertensives, as earlier pointed out. If they have underlying diseases like hypertension, diabetes, endocrine or hormonal disorders that can affect sexuality, we want to first treat those. And for men and women with those hormonal deficiencies, we want to replace them. For men, we want to replace the male hormone testosterone. Even women need a level of testosterone for sexual desire, plus other drugs. Okay, now let's look at the desire and arousal disorders in females. Like I said, females require a level of male hormone called testosterone for them to have sexual desire. And if they have insufficiency of this hormone, either through surgery or because of menopause, then they can have low desires. If people have chronic diseases like renal failure, those are kidney dysfunction diseases, okay, they can also have problems. So you want to first optimize their kidney functions. We already talked about a hormone prolactin. This is a hormone that enables women to produce breast milk. But if you have someone producing milk outside pregnancy or when they are not lactating, then they could be producing this hormone from other places like brain tumors, from kidneys and adrenal diseases. So we have to first treat that. Of course, we know pregnancy and lactation is a time that can affect sexuality. Some women experience low desire, others have enhanced desire during these times. So we have to put that into consideration. Of course, we have social problems, longer durations of relationships, marital problems, low partner attractiveness. All these can affect the desire and arousal, and we have to address them psychologically. Affective disorders, people who are on treatments with antidepressants, we have to also address those. Those with psychotic disorders, we have to also handle. Of course, if other people have sexual dysfunction as a result of other problems like erectile dysfunction, premature ejaculation, they end up getting desire problems. They feel low esteem and their desire go down, and sometimes they avoid sex. Okay, of course, negative social attitudes, okay, including teachings from religions, all these can affect the way people look at sexuality. Now, having looked at that, we sometimes run a number of laboratory tests to find out what the problem is. Okay, we look at the fasting blood sugar levels. We already talked about diabetes and other metabolic problems as causes of sexual dysfunction. So we have to be sure that they don't have diabetes. We look at lipids. We know when people have abnormal lipids in their body, these ones can block the smaller vessels. And as I will tell you, sexuality, especially in men, is dependent on good function of blood vessels. We need blood to flow to their genitals for them to achieve an erection. So bad lipids can be a problem. For men, we want to know that their male hormone testosterone is in normal levels. So we measure it in one morning. We usually take this level in the morning because we expect it to be high towards the morning and not during the day. Then there are other hormones that are luteinizing hormones that are produced in the brain that control how the genitals work, how the gonads produce other hormones. Of course, we measure other hormones like prolactin. We assess the function of the thyroid gland. All these we know can affect sexuality. Now, how do we manage the hyperactive sexual desire, the low desire problem? One, for men, we want to know the levels of testosterone. If it is low, that is less than 7, we start giving them testosterone replacement therapy. We have a number of drugs, okay, containing testosterone, either tablets, injections, or even creams that we give these men. Okay, even for women, especially those who have advanced age towards menopause, they tend to have low levels of testosterone, and we enhance their sexual desire using the same testosterone drug. Of course, addressing other issues of sexuality like premature ejaculation, all those are things we can do. And dealing with depression, withdrawing those antidepressants is also something that we can do to enhance sexual desire. Dealing with psychological and relationship issues is also another big thing that we do to help people have enhanced sexual desire. And that's where we involve in counselors, psychotherapists for that aspect. Now, we also have other disorders called arousal disorders, which we also call erectile disorders in men. Of course, we said in men, arousal will present as an erection, whereas in women, arousal will present with good lubrication and production of genital fluids. So if we have disorders in those two aspects, now we have drugs. For men, we use drugs that enhance blood flow to the genitalia. We have drugs that open up the blood vessels or dilate those vessels, and therefore blood flow will go to the genitalia, and it is this blood flow that makes the man's penis erect, become hard, and be able to perform sexually. We can also add other drugs we call serotonin selective receptor inhibitors, because we know a hormone serotonin is also involved in the process of sexuality. Then sex therapy. Sex therapy is another approach that we use, okay, especially those who are battling psychological problems, social problems, and the like. Of course, when we have other medical conditions that are implicated in sexual dysfunction, like diabetes, hypertension, vascular diseases, hormonal disorders, we again have specific treatments for those, and they end up helping with erection and arousal. This picture tells you exactly what happens to a flaccid penis. The first picture here is the penis which is flaccid at rest. In this, we have blood flow cut off, okay? And we see blood vessels penetrating the tissues of the genital. But when blood flows into this structure, it enlarges, expands, and becomes rigid, and that's how an erection is achieved. So if we have issues with blood vessels in the male genitalia, then we have issues with erection. Again, the same thing here, telling you the same. We have other non-pharmacological measures. These are measures that don't employ drugs, but also end up helping with solving erection problems. We have mechanical aids, including vacuum devices. We have penile implants that all help men achieve an erection. Okay, and these are reserved for severe cases when other approaches have failed. Okay, and we also have diureters for women. We sometimes find women with issues to do with the size of the vagina, and that can be a problem. So with the diuretation, it helps them to perform sexually. Then vibrators can also help stimulate women, then be able to achieve climax. Now, sex therapy. This is usually offered by those specialists called sex therapists, okay? And this is to deal with the psychological problems that affect sexuality, as earlier pointed out, issues with marital and relationship problems. So once we handle that aspect, sexuality, arousal, desire, and performance is all improved. Now we also have behavioral therapies, okay, where we have techniques that change people's behaviors in their relationships. Some behaviors can affect people's sexuality. Some sexual techniques can also be a problem. Okay, so all these behaviors can be changed. Other good ones can be enhanced. Now we also have psychotherapy, okay, where we have where we address sexual trauma from the past. Okay, this can affect the desire in future. Anxiety problems, fears, and guilt. People who have negative body image, all these can be cancelled to start looking at themselves in a different perspective. So we also have mind training exercises like destruction. For men, especially with premature ejaculation, usually pleasure makes them climax very fast. So what we teach them is to distract their minds from that pleasure. We also have exercises like start, stop, and start. This is where a man feels they are almost reaching climax and they withdraw or they stop the thrusting actions during intercourse. And when this intense pleasure is lost, then they are able to start again. Then we teach pelvic muscle contraction exercises that can also enhance performance. Now for women, we have many other organic factors that are related with sexual arousal. The female hormone estrogen is very, very important in lubrication. So in postmenopausal women, or those women who are aged advanced, we usually find them with low levels of estrogen. And therefore they have lubrication problem, which may lead to painful sex and other disorders of sexuality. When it comes to desire in women, we also give them male hormones, the androgens or the testosterone we talked about. These ones improve their desire. Then the other drugs that increase blood flow to genitals, we don't use them so much in women, but occasionally they also do. help. And we need a fully functioning nervous system for men and women. So when we have problems at the level of nerves, we also give drugs that stimulate and enhance nervous function. Then we already talked about the medical problems, heart diseases, fat problems. All these are things that we can correct. Now, lastly, we are looking at pain disorders that my colleague alluded to in the beginning, and we analyze the cause of this pain. Okay, some people feel pain when they just think about sex, even before the intercourse itself. Others feel pain during the intercourse. Others feel pain after an orgasm, after the performance. So we find out where the problem is. Sometimes the cause is physical or sometimes psychological. So we take a simple history. We ask them if they have ever had infections in the past, or if they have the infection currently that is very active, that can cause pain. Then we look at some people have genetic problems, a familial problem, where even the relatives have that genital pain. So we ask them. Then behaviors, we ask them if they have used the tampons, if they have had sex before the age of 16, if they have had trauma to their pelvic floor. Then we ask about the psychological setup of this person. Do they have a negative mood? Do they have hypervigilance? Have they had trauma in the past, especially sex-related trauma like rape? Then we go to the physical part. Have they had a physical trauma to their pelvic system or to their abdominal system? Any injuries on the spine? Those ones can interfere with the nervous system that goes to the genitalia. If they have ever undergone through treatments like cancer therapies, radiation therapy that can affect their nerves. Of course, we also know that hormonal problems can affect these people. That's where we find out if they have vaginal atrophy. That is where the lining and the muscles of the vagina become small, they shrink, especially in menopause. Then we ask them if they have ever used hormonal therapy. We have to find out, are they pregnant or not? Okay, some people experience painful sex during pregnancy. Then we ask about contraceptives. The pill plan or the oral contraceptives we know usually reduces sex desire and arousal, and that can lead to pain. Okay, and we also know pain during ovulation. Okay, although we know lubrication is better during the ovulation time. So those are some of the aspects we have to look out for when we are dealing with painful sex. And the treatment will be directed to the cause, where we use medical therapies, drugs, or we use psychotherapy, sex therapy, relaxation exercises. And as I said, once the cause is known, it will be treated. And like my colleague said, a number of people have causes that we can't find out. Okay, and with those people, we give them combination therapies where we use medicines, we use counseling. Okay, or sometimes we only observe and teach them to change a few things in their lifestyles. This brings us to the end, and we welcome questions.
Wow, thank you so much. This was well elaborated, and I believe members are picking a lesson or two. I will read some random questions, then you can give responses as they have been sent in by members. Okay. I see members who have raised their arms, but to you, Dr. Hilary, somebody asked what causes failure of penis erection and immature. I think this was pretty much ejaculation. Then they're asking more explanation on vaginismus. Okay? That's another. Then the third is, how does a vagina fail to relax? Dr. Hilary, you can respond to that. And also, how is prolactin related to sexual function? You can respond to those, Dr. Hilary, and then we get more. We shall give some members a few minutes to ask their questions, but kindly, Dr. Hilary, first respond to those questions. Thank you.
Thank you, our host. One about vaginismus. Vaginismus, we mean that the muscles of the vagina squeeze or spasms. Spasms are like squeezing, relaxing when something has entered the vagina. It can be a tampon, but in this case, it is the penis that we're talking about. And what happens is any stressor, it can be a physical stressor, but the commonest is emotional stressors. That is why most of the people whom you've seen in the Buke Day, Gatari Konfufu, that a man was in a lodge with someone's wife, and then they got stuck each other until they brought a witch doctor to pray for them, and they separated. Usually, the cause is actually that yes, there was vaginismus. The vagina walls squeezed the penis inside, and they can't release it because of emotional stress. And maybe when the witch doctor was brought to pray for these people, it separates. It's quite common, and it's a known medical condition. About prolactin and sexual function, there are a lot of studies that show that actually up to 88% of males who have raised prolactin levels have erectile dysfunction or difficulty achieving an erection. And the major problem here usually is that it is associated with the decrease in serum the other hormone Dr. Masembe talked about, testosterone levels. Of course, when someone has hyperactin, they should be investigated. I think those are some of the questions, if I have not forgotten the others. I saw in the chat someone asking about masturbation and its effect on erectile dysfunction or impotence. Of course, there is no evidence as per research and studies that suggests a reduction in sexuality or an effect of masturbation on sexuality, especially erectile dysfunction. But what we know is that the effect of masturbation is largely due to the psychological effects and its effects on self-confidence. And of course, someone who knows they can always masturbate are more likely to have a reduction in sexual desire, or will even need higher stimulation for them to be sexually aroused. But there's also evidence that masturbation may result in loss of sensation, of course, again, which means low drive. Yes, I think those are the questions that there is any. I haven't talked about causes of failure to erect. We talked about them. We said up to 90% of the causes are due to psychogenic factors that we have talked about, but also we also know that for a number of others, it will be physical, the diseases that I've talked about and the drugs that we have talked about, I think, in detail. Thank you.
Thank you so much, Dr. Hilary, for the good responses. I hope members are learning. Then there was another one. Is there a medical cause for sexual addiction? If yes, what is that cause? Then you can take it on with this one. Can low testosterone in women cause sexual dysfunction? Are there any side effects associated with use of energy drinks on one's sexual health? You respond to those, and then I'll give you what somebody sent me in box, and then we'll go to Dr. Masembe. Thank you, Dr. Hilary.
Yeah, thank you. So about low testosterone, yes, low testosterone in women also can result in reduction of libido, especially now these women.
There is an echo. We are muted.
Yes. Am I clear now?
One of you should mute, Dr. Hilary and Dr. Masembe. One should mute their microphone.
So I think we are now together.
Yes, you are clear now.
Thank you. So yes, it is true. Low testosterone levels result in sexual dysfunction in women. And that's why we see this close to their menopause, because the levels of testosterone will go down. What's the other question? Yes, so medical causes of sexual addiction. There are really not many, not a lot of documentation is available, but largely it's behavior, the environment one has grown in, or their experiences as children, or their lifestyle. For some who are involved in watching a lot of pornography, they may. Unfortunately, you can't know how one will fall. Some may become hyper because of a lot of pornography, others may become hypo. But there are not so much known, there isn't so much known. So I think that is all.
Oh, okay, thank you so much. Kwichiliza Fred, could you unmute your microphone and please post your question? Thank you.
How are you?
Yeah, good. How are you?
Fine, thank you. I have a concern. I have a friend who only functions after he has taken alcohol, and now he wants to quit alcohol. How can he handle it? He only, going extra mile during the exercise. He only does that when he has drunk something. But now he wants to quit alcohol. What advice do you give him?
Dr. Masembe on management, I think that goes to you. Thank you so much.
Okay, thank you. I think that goes hand in hand with the psychological setup we talked about, the esteem. Some people get self-esteem elevated when they have taken 1 or 2 bottles, and when they have not taken that, then they go down. They cannot even initiate sex. Of course, there are also very many ways people respond to alcohol. Some people have their mind is stimulated when they are drunk, okay, and when they are not drunk, they cannot. So that is also the way alcohol can affect them. But esteem is also one of the pathways the people usually go around esteem issues by first taking alcohol. So that's what I think is related with that.
Okay, thank you so much. Earlier alone, I received a question in one of my media chats, and somebody was like, some men stress women asking them for water when they are in the first place, don't know how to look for that. This lady is asking, how can she be helped? What do you expect a woman to do in such a scenario? Thank you, Dr. Masebe. This goes to you.
I didn't get the question clearly. Can you ask again?
A lady mentioned that some men stress women asking them for water when in the first place they don't know how to look for it. So this lady was like, what do we expect the woman to do, or what do you advise her to do as a lady if the man is asking and he's not able to look for that? What does she do in that case? Thank you so much.
Okay, so the whole myth about water during intercourse is cultural. There are some cultures that believe that during intercourse, women must pour out a gush of fluid as part of their excitement or as part of their orgasm. And this usually goes culture by culture. And in many times, most women will not experience this. What is basically important is that they are able to lubricate themselves. If they can get good lubrication during excitement phase, that's all that is required. But this myth of water, some people have said it's actually urine that comes involuntarily during sexual intercourse. Other people have had arguments that this is water from the genitals, not urine. Whatever it is, no one should be stressed about it as long as lubrication is adequate during intercourse. That's all they should aim at. Okay.
Okay, thank you so much. Hope she gets helped. Retinoblastoma. Could you unmute your microphone and please post your question? Retinoblastoma. I can't read your name, that's why I'm reading that.
Thank you for the opportunity. I was inquiring about the sperm bank. Recently, I saw in the media circulating that now Uganda have services of the sperm bank. I was inquiring whether the Neo Clinic has that has already started providing that service, and if so, can some of us come and donate because we have idle sperms here?
Okay, thank you so much. Dr. Hilary, could you respond to that?
Thank you, Chair. Yes, at NeoCare Clinic and Fertility Center, being a fertility center, we also appreciate the role of sexual function disorders in infertility. A male who has issues achieving an erection will most likely, that couple will come in because they are unable to have children. I mean, it's quite hard. So we, in the first place, aim to manage the disorders with the number of the management procedures that we have talked about, the management protocols that we have talked about, but also those that require more advanced technology, we are able to refer them. But the good news is that most of the causes are actually manageable. Maybe I can say to 90%, they are manageable. Thank you.
They were asking. Okay, maybe to
yes,
supplement on that. The question about sperm banking, we have a sperm bank here. We are able to store sperms up to 10 years. We usually screen sperm donors. We also have a sperm donation program. We have also an egg donation program. We have couples that are unable to achieve a pregnancy either because one of them don't have eggs or the husband doesn't have sperms. So those are able to achieve pregnancy through sperm donor programs and egg donor programs. Even those who want to use their own sperms to achieve pregnancies, they can store. For instance, someone may be wanting to travel next month and the wife wants to conceive next month. They leave with us their sperms, we store them. And at the time they want to conceive, we simply inseminate. So we do that. And for people who are interested in sperm donation, we have a very good allowance for them. We call it a facilitation allowance because we don't buy sperms. Even for eggs, those who are eligible to donate, we also give them a very good facilitation allowance. And we first screen them to be sure that they are eligible for donation and they don't have any difficulties, any issues that will later on be a problem. So the answer is yes, we do the sperm banking here with us.
Thank you so much. Charimpa Rose, could you kindly say aloud your question?
Thank you. My question is there any medication for sex addicts?
Sex addicts. Dr. Masembe, would you like to respond to that, please?
Yes, thank you. About sex addiction, we basically do both approaches, the psychosexual education, behavioral change, And then if we think there is any medical problem related, then we treat it. And sometimes we do what we call sensitivity reduction therapies. Some people have got continuous genital stimulation disorder, where all the time they feel they have an erection. Even in women, we call it a persistent genital stimulation disorder. So those, we give them drugs that depress their nervous system so that their sensation is reduced. And in worst cases, we do surgeries to cut off some of the nerves from supplying their their genitals. But if the problem is psychological, behavioral, then we very much dwell on the behavioral therapies and psychological therapies. Thank you.
Thank you so much, Dr. Masembe. I have somebody with a concern in the chats, and her question goes: my hubby has a good penis, but I only desire his touch-like stimulation around the genitals, commonly known as fingering. She asks, is it normal? Then goes ahead and says, we only have sex 3 times in a year. What can we use to get better? Management, Dr. Masembe, help somebody, please. Thank you. Dr. Masembe, did you get that?
Sorry, I didn't unmute. We said in our introduction that males and females respond to sexuality differently, and females usually are stimulated by tactile stimulus. So that is to do with touch. And some people, even a mere touch on their neck, a mere touch on their breast is enough to excite them and even go through the whole cycle that Dr. Hilary talked about up to climax. So, and that tells you how important a mindset is in the process of sexuality. If you set up your mind at an orgasm, anything simple can lead you to orgasm. And it is also to do with training of the mind. So if this lady has spent most of her time and mind and in sexual practice and real believes in touch, usually that enough can take her through the whole cascade of sexual response that we saw. Then about someone who said they are able to meet with their partner only 3 to 4 times a year, we want to know why. Is it the problem to do with the desire? Is it the separation because of work, because they stay apart? We need to know what the problem is. But we know, generally speaking, an intercourse of 3 to 4 times a week, okay, is what is generally observed in many couples. So 3 to 4 times a year is quite infrequent, and the reasons for that need to be explored. And if any of the things we talked about is a problem, then we need to help that couple. Thank you.
Thank you so much. Infinix S4, could you kindly unmute your microphone and air out your question, please?
Yes, doctor. Thank you so much. I have a couple for 3 months now undergoing counseling. Both of them can undergo through the 4 phases Dr. Hilary said. Excitement, very well. But the male, when he reaches the plateau phase, the erection goes down and the penis becomes soft, like gets erectile dysfunction, and is able to reach orgasm. So I'm still wondering how I can help this couple, doctor. That's my question.
Wow, thank you so much. Dr. Hilary and Dr. Masembe, any of you should respond to this, please.
Yes, so this is a part of the premature ejaculation complex, okay? So because the definition Dr. Ira told you is very clear, it is premature ejaculation if it happens before penetration or slightly after penetration or before 5 minutes. So it matters how long and when this happens. So if you think it's more than 5 minutes, it means this man was able to stay stiff for some time. So it doesn't matter whether he ejaculates during that relaxation phase or not. But what is generally observed is that ejaculation happens when still an erection is on, although some people still bring out the fluid when the erection is disappearing. So we need to know those details with that couple. We need to take more questions from them and understand what the problem is exactly. Thank you.
Wow, thank you so much. I hope this person can get you and maybe you see how to help her out. Or Infinix X4, did you want to say something to clarify your question?
Yes, I wanted to clarify my question. The orgasm comes when he has just entered, but when the erection is down, like the penis is soft. And it happens after 5 minutes. It can take almost like 10 minutes, but still when the penis is no longer erect.
Okay, fine. We know even ejaculation has got phases. We have that expulsive phase, okay, when the semen is expelled into the urethra, and we also have the emission phase when the ejaculate is able to get out of the urethra. So some people, you find those phases occur concurrently, both the expulsive phase and the emission phase. And the expulsive phase usually happens when the erection is at its peak, and then the emission can occur anytime. Okay, like still, I told you, we need to get more questions about those two. As long as eventually this climax happens, we have no problem with it. The problem happens if it doesn't occur. Like they told you, some people have anorgasmia. They can even reach climax, but they never ejaculate anything. Some people call it a dry orgasm. Some people, it can be retrograde ejaculation, where semen instead goes into the bladder of urine instead of coming out. But if this semen eventually comes out, doesn't matter whether it is still stiff or whether it is already detomized or already softened. Okay.
Thank you so much, Dr. Masimba. I think what you have just responded to is related to what someone sent me, that some men ejaculate empty or air. This is what the lady wrote. And she was like, how do we help such men who ejaculate air?
Okay, that's what I already talked about. Okay, they call dry orgasms or anorgasmia itself. Okay, and the causes can be a number. One, we could be having no production of semen itself. We find the glands that are supposed to produce that fluid are not doing it. Sometimes the fluid is produced, but it is unable to exit and come out. Maybe there is an obstruction along the urethra. Or some people have got problems with their nerves. We said this process requires a functioning nervous system. If that system does not work, for people maybe who have had surgery, like people who have had prostates removed, people who have diabetes and their nerves affected, many of them may not reach that point of emission. Okay, the ejaculate may stay in the urethra or sometimes go retrograde, go the opposite direction into the bladder. So that is the explanation.
Thank you so much, Dr. Masembe. Techno, come on, 16S. Your arm has been up for long. Please air out your question. Techno, come on, 16S. I'm not seeing some names, that's why I read what I see. If that person is not yet ready, could we listen to Ruth Kamara?
Hello? I'm ready.
Okay, please, get in.
Thank you so much, Dr. Masemba and Dr. Hilary, for that great work done. My question goes to what if a patient is brought in with the penis stuck into the vagina? What could be the management? Then again, back to the waters, Dr. Masembe. Are those waters scientifically known, or because we talked about it being cultural? Yes. As to the medical science, is it there, and where does it come from? Thank you so much.
Dr. Masembe, could you respond to that? You are still muted. I hope you are not talking behind the muted mic.
Yes.
Sorry, get in. I was trying to unmute you. Please unmute again, Dr. Masembe.
Okay, fine. You can hear me now.
Yes, we can.
Yes, there are some instances. So the last one happened in Kenya not many years ago, where someone was brought into the hospital with a penis stuck. That is an extreme case of vaginismus. That's where the pelvic floor muscles of the woman, okay, involuntarily contract, and it is usually a psychological problem. So all we need is to give these people muscle relaxants. Once you give muscle relaxants of the vagina, relaxed, they will eventually come out. Medical management using muscle. Sometimes we give psychotherapy. Sometimes you have to give psycho inhibition drugs that we also use, like serotonin receptor inhibitors, that eventually achieve the smooth muscle and the skeletal muscle relaxation. Not in many instances where surgery has been done. Most of these people have improved by medical interventions. The other question about the waters, okay, that I said some cultures learn about these waters and they think it is a measure of sexual performance. Many studies have been done. There are articles that I can share that I've read about comparing those fluids and trying to see the chemical composition of those fluids. Many studies found it is actually urine. Okay, and it's logical. In our experience and understanding of the functioning of the genital system, we don't really see where that fluid should come in that amount that people really see that can cause a flood. So many times it is not just a vaginal fluid, but urine. Then in other few studies, they found it is actually vaginal fluid. There was no ammonia. Ammonia is a component in urine.